Recording. Okay, we're good now. All right, so we're starting with the nose, and in the nasal cavity, you have these folds. These are called the nasal concha, and the term isn't as important as knowing what it does. So as air comes into your nose, it's coming in at a really high speed, and we need to do a few things with this air before it can get down into your lungs. And one of the things we need to do is slow it down so that we can clean the air. So inside the nose, you know, you've got hair, you have mucus, and as the air comes in and hits those nasal concha, it kind of causes the air to swirl. So it stays in the nose for a little bit longer, all right, because of that swirling, and allows the cleaning process to occur. Now, something else that also happens due to the swirling is that the air is going to be warmed up. Underneath the surface of the nasal epithelium, we have really large veins. These are actually called venous sinuses. They look like little sausages. They're so stuffed with blood. That's why, you know, you get hit in the nose. It's so easy to get a bloody nose because you've got these big veins right there that can rupture. Now, because you have this vein that has a lot of blood in it, whenever blood comes in, it kind of slows down and sits in that vein for a while before it goes out the other end. And blood radiates heat. Now, where we get the heat from in our blood is that every single chemical reaction that we do in our body, one of the waste products is heat. And that heat, if it builds up in our system, we're going to overheat. So the heat goes into our blood, and then the blood transports it closer to the surface of the body so the heat can radiate off. And of course, one of the places it's radiating off is inside the nose. And so we're going to heat the air as well. So we're cleaning the air, we're heating the air, and then we're also humidifying the air. And we just talked about this. I told you that wherever you have excess blood hanging out in a vessel, there's going to be an increase in pressure. And anytime you have an increase in pressure, some of the fluid is going to get pushed out of that vessel into the tissues. Well, in this case, fluid is being pushed out of the vessel, and it's being pushed into the nose cavity, and it's like it's, you know, just misting inside the nose. And so your air is going to be 100% humidified. That means it's just packed 100% full of water as it enters into the nose. So we are warming the air, we're cleaning the air, and then we're also humidifying the air. The lungs are very sensitive tissue, very sensitive. Matter of fact, you can think of your lung tissue kind of like tissue paper. Okay, you know how thin tissue paper is. And now imagine tissue paper 1,000 times thinner. And that's how thin your lungs are. And your lungs cannot take a lot of dirt and things getting in there before they start to tear. And they also cannot handle it when it's too cold or it's too dry. And you've probably experienced this if you've ever been outside and it's really cold, it's really dry, and maybe you're running around and breathing in through your mouth a lot where there's no humidifying the air going on in the mouth like it is in the nose, and your lungs start to hurt after a while. And that's because you didn't warm the air up appropriately, you didn't put enough water into the air. And if you do expose your lungs to this really cold, dry air for too long, too much, you can cause damage. And some people end up getting like pneumonia, things like that. So very important, clean the air, humidify the air, and also heat the air as it goes through the nose. Now, at the back of the nasal cavity, there's actually a little lymph node that sits here. There's also a lymph node that sits at the back of the tongue and in the back of the throat, just in case we have to breathe through the mouth. These lymph nodes are also there to help to clean the air, and what they do is they catch bacteria and viruses. The one in the back of the nose, in the back of the nasal cavity, we call this the adenoid. So if you've ever heard somebody has to have their adenoids taken out. The ones in the back of the throat, these are called tonsils. They're really lymph nodes. They just get special names because of where they're located. But they're there to filter out bad guys, bacteria, viruses, so on. Now, once air gets through the nose or gets through the mouth, either one, it's going to go to the back of the throat, which is your pharynx, and then move to the front into your larynx. and then down into the trachea. Now I want you to notice this setup. Your larynx and your trachea are to the front. Your esophagus is to the back, okay? So when we talk about the digestive system, kind of keep that in mind. The esophagus sits right behind the larynx and the trachea. So the air is now going to go into the larynx, and this is the setup of the larynx. There's a couple important things about the larynx you need to know. One, the big deal, is in the larynx you have vocal cords. So as we exhale, the air that we're exhaling are going to hit on these vocal cords, this connective tissue, and cause it to vibrate. And as those vocal cords vibrate, they create a particular sound. Now, the sound of your voice is also due to the fact that you have sinuses in your skull. The air swirls in there, and that creates a certain sound for your voice. And your vocal cords in the back of your throat, the back of your cheeks, they all create a particular sound, which is also why when you hear your voice, like, you know, somebody's recorded your voice and you're hearing it, it doesn't even sound like your voice to you, because your voice is resonating all in your head, and it sounds totally different to you than it does to someone else. And maybe if you have like a sibling, or, you know, maybe your mother or father or something like that, you may sound very similar in voice to them. Like, you know, the new cell phones where you can just talk to Siri without pushing a button. Every single one of my kids, my female children, can all get my cell phone to turn on by just saying, "Hey Siri." It's like, dang, we must all really sound very similar, because Siri has absolutely no idea who's talking to her. So it's really very interesting, and it's because of the genetics. Things are going to be shaped very similar from one sibling to another within a family. Now, in order to change the pitch of the sound of somebody's voice, what we have to do is we have to change those vocal cords. Now, a couple of different ways to do it. Notice, okay, so right here in this overhead, this is a picture of the vocal cords right here. And in front, we have the thyroid cartilage. In back, we have the arytenoid cartilage. Now, those aren't really important, except for you to know that the vocal cords are attached to these two cartilages, okay? And the arytenoid cartilage kind of reminds me of, you know, like the arm on a slot machine. You can pull it back and forth. And we have the ability to pull this cartilage back and forth. It's actually attached to skeletal muscle. And you can pull that cartilage back and forth, and what it does is it stretches and releases your vocal cords. And every time you stretch it, the pitch of your voice goes up. And when you release it, the pitch of your voice goes down. So if you want to sing real high pitch, you're going to stretch those vocal cords out. And if you want to sing lower pitch, you're going to release those vocal cords. Now, you and I don't even think about it when we do this, and we do this all day long, because obviously we're talking. But this has now become reflexive. So if you're ever watching a little baby learn to talk, you'll see, you know, they're making all kinds of weird sounds. It's because they're learning how to control those vocal cords, as well as, you know, some of the muscles in the throat to like make the g sound and things like that, and how to put the tongue in the face and all that in order to be able to make these sounds. And then once they get it, now it's reflexive. But around puberty, if you have a male child, their voice starts to change somewhat because of testosterone levels. Now, testosterone can affect the vocal cords directly. It can make the vocal cords get much thicker. The thicker the vocal cords, the deeper the voice is going to be. The other thing that happens is testosterone affects the thyroid cartilage, and that cartilage is going to grow. Now, that thyroid cartilage is also what we would call your Adam's apple. So if you see an Adam's apple protruding from someone, it's actually the thyroid cartilage. And with males, that gets much bigger because of the exposure to testosterone as they go through puberty. Now, one of the problems is, though, when the male gets a spike of testosterone, that thyroid cartilage will pull forward. And as it pulls forward, it pulls on the vocal cords, and this is where you hear the little boy's voice, you know, do that twang thing, okay? And that's because all of that is changing in there as, you know, he's gone through this puberty stage. Now, looking down on the larynx, okay, these are the vocal cords here. And again, the air is passing through, coming up through the larynx, making these vocal cords vibrate. Now, if you use your vocal cords a lot, so maybe you're, like a teacher, or you're an opera singer or something like that, those vocal cords are vibrating all the time, and sometimes what will happen is the edges will start to hit on each other. And because of that, the vocal cords can get really sore, and they can start swelling up. And really, the only cure for that is to shut up. You just have to stop talking and let them just come back and heal, drink some warm tea or whatever, help to take the swelling down. But some people, they need to keep talking. They can't stop talking because maybe it's part of their job or something they can't take off. I'll give you a story. This happened probably before most of you were even born. But in California, way back when, we had a governor whose name was Pete Wilson. And Pete Wilson was a pretty popular guy, and a lot of people thought that he was eventually going to become President of the United States. And so Pete Wilson decided he was going to go around, doing the campaign thing and talk and all kinds of stuff. And he got a sore throat. And his vocal cords were all swollen. Now, if you don't be quiet, if you don't stop talking, what will happen is you'll start growing these little, what we would call nodules, these little growths of the connective tissue along the edges of the vocal cords. And now those little growths hit on each other as you talk, and that is very, very painful. And again, you got to be quiet. You've got to stop talking. But if you can't stop talking or you refuse to stop talking, there is a surgery that can be done. And you can have those little nodules cut off of the edge of the vocal cords. Now, Pete Wilson was told, you need to stop talking, and he's like, look, I'm running for President of the United States. I can't stop talking. I need to give all these speeches. I need to keep going. Cut these suckers off. And so he went in for surgery. Problem is, if you even slightly nick the edge of one of those vocal cords, it can change your voice. Now, obviously, we don't have a President Pete Wilson anywhere on that list. So something happened when he went in for surgery, and even though he had one of the best surgeons around, they slightly nicked the edge of one of his vocal cords. And now Pete Wilson, who is never seen talking in public, talks like Mickey Mouse. So it completely ended his career, and some totally unknown bozo nobody had ever heard of from some podunk South Arkansas, who cares, state named Bill Clinton took over. How weird. Probably would not have beat Pete Wilson because he was so well liked and so well known. But who was going to vote for a guy who sounds like Mickey Mouse? Absolutely nobody. We would vote for Mickey Mouse as Americans. We would do that because, look, we voted for Trump. We would vote for Mickey Mouse, okay? And I heard that the next president of the United States is going to be The Rock. I would vote for him just so I could look at him, okay? I don't care what he stands for. He's got the woman's vote as long as he gives speeches with his shirt off. That's all that man's got to do. Check, I voted for him, okay? Anyway, yeah, I already see it all over Facebook. The Rock for president.
Of his voice?
I don't know. I'll have to look at YouTube and see. I'm not sure. But he really does sound like Mickey Mouse. He really does.
Well, when it gets cut, will everybody's voice sound like Mickey Mouse?
No. You can have some people, they squeak in different ways, but I mean, it just ruins your voice. And it's just the slightest little nick. So you're best off, just like writing on a piece of paper and not talking. Yeah. He should have had somebody else go out and campaign for him, but that it's not the same as if he did it.
When you talk about voices changing, how you'll run into some guys that still have a high-pitched voice.
Yes.
Is it that their vocal cords didn't thicken up enough, or it's not enough testosterone?
They didn't thicken up enough because they didn't have as high levels of testosterone.
Okay.
Yes, that is typically the reason why. Mm-hmm. Now, the air is going to go from the larynx down into the trachea. And if you remember from anatomy, you've got the trachea. It's not very long, maybe about 4 inches long. It's got some C-shaped rings going on here. and it's got a little piece of muscle to hold that C-shaped cartilage ring in place. And then you don't have to write this down, but I just love saying it. It is lined with pseudostratified ciliated columnar epithelium. I just think that's so cool. I just love that name. Okay, it's just me. All right, but here's the big deal. Your trachea is lined with cilia, okay? And that is very important for you to know because this is another protective mechanism very similar to the nose. So what's going to happen is this cilia is going to help us to keep dirt and debris, whatever it is, from getting into the lungs. So what the cilia does is it's totally beating upward all the time. And we make a little bit of mucus in the trachea as well. And so whatever the nose didn't catch, or maybe I'm breathing through my mouth and didn't catch anything, the trachea hopefully will catch. So all those dust particles will get stuck in that mucus, and then the cilia will beat it upward, and then you're slowly swallowing that all day long. You don't even know that it's there, unless you're like nasty and, hawk it out the window or something like that. Anyway, but that cilia is very important. Now, the cilia, I will tell you, is super duper sensitive to what we would call particulate matter. So particulate matter would be like dust in the air, or if somebody took baby powder and whoosh it into the air and you got all this baby powder in the air, that's considered particulate matter. And if the cilia is exposed to too much of this at one time, they'll freeze. They'll become paralyzed. It's like they're overloaded, they don't know what to do. So for instance, if somebody smokes, now it doesn't matter what they're smoking, they can smoke marijuana, smoke speed, smoke cocaine, smoke cigarettes, absolutely doesn't matter, because that's a lot of particulate matter when you're smoking. What it does is it paralyzes the cilia. So for instance, let's say somebody is smoking a cigarette. If they smoke a cigarette, okay, just one cigarette, your cilia, that person's cilia will be paralyzed for 1 solid hour. So that means all the particulate matter that they just smoked, and there's a lot of it from cigarettes and speed and marijuana, but all of that will go down into the lungs. And that lung tissue can become damaged from that. And so you can cause, especially if you're doing this over time, you can cause a lot of damage. So when people say to you, well, marijuana doesn't cause damage, it doesn't cause cancer, it doesn't cause... It is not true at all, because if we just talk about this, marijuana, just like cigarettes, has a lot of particulate matter, okay? A lot of chemicals float down into the lungs because it paralyzes the cilia. And it gets deep into the lungs, and eventually, we'll talk about this a little bit more as we go along, but it will destroy alveoli, okay? And if the alveoli are destroyed, you can't breathe. You can't exchange gases. And this is part of, we'll talk about the rest later, but this is part of the disease of emphysema. Question?
Is it the same with secondhand smoke?
Yes, it is, depending on how much you've been, exposed to. So, for instance, people who used to work, like maybe a bartender or whatever, in a bar when everybody was allowed to smoke, those people were much more likely to develop emphysema than even the smoker who was there for that day, because they were constantly exposed to all this particulate matter in the air. Now, if I'm in a car and somebody's smoking in the car and it happens to me one time, I'm not going to get emphysema. But if I'm a little kid and my dad smokes all the time in the car, can I develop problems from that long term? Oh, heck yeah.
Is it the same with like vaping? Because I know a lot of people vape and they're like, no, it's fine, it's just straight nicotine, nothing else. I'm like, you're still smoking, you're still getting smoke in there.
Yes. Yes, it doesn't matter what the particulate matter is made of. For instance, we don't even have to talk about cigarettes or vaping or marijuana. Just stand outside in the high desert when it's windy, okay? And you're breathing all that dust and everything in, you probably paralyzed your cilia for about an hour. So anything that basically overloads that cilia, they're just like, okay, I'm out of here. I got to take a break. This is too much. And then, of course, that can cause damage to the lungs. Question?
So cilia is supposed to be the secondary protective mechanism
Right.
to keep out bacteria and bad things into the lungs, correct?
Right.
So as far as the adenoid and the tonsils are concerned, do they just not do their job very well, or are they just not as easily susceptible to
They
bacteria?
do their job just fine, but if I expose myself to a lot of particulate matter, they can't keep up. So they can only do so much. So so we have to have multiple mechanisms. So you have the nose, you have the tonsils, you have the cilia and the trach. We have multiple mechanisms.
One more question.
Yeah.
When it comes to the tonsils, they're constantly recommended for people to remove them.
Yeah.
Why?
Well, okay. The medical profession swings back and forth. So for a while, remove tonsils. For a while, don't remove them. Now we're back to, okay, remove them. You have lymph nodes, lots of lymph nodes, hundreds of them throughout your whole body. So if I take one or two out, it's no big deal. Your appendix, nothing but one of hundreds of lymph nodes in your intestines. So if I clip your appendix out, no big deal. One is gone, you've still got hundreds more. So the problem is when somebody's tonsils need to be removed, it's because those tonsils are failing. There's something wrong with them. They're not working appropriately. They are overloaded with bacteria. They can't keep up the job. And give the person antibiotics to get rid of the bacteria because the tonsils can't do it. And then the tonsils come right back with another bacterial infection. And so if the patient has infection after infection after infection, then it is more healthy to remove those tonsils because now they've just become a house for bacteria. And so it's better to remove them because one of the other problems is those tonsils can swell up also. And they can get so big, they can fuse and close off your throat and you can't breathe. So you do not want that to happen in your patient. So it really depends on the doctor. Some doctors are right at it. Okay, you've had 3 infections. We're getting rid of these things. Some doctors, you've only had 12 infections. You'll grow out of it. You'll be okay. It kind of sort of depends. The other problem is too, especially if you have little kids who have a lot of infections in the tonsils and potentially also in the adenoids, you'll really know that they're swollen all the time because they snore horribly. Really loud snoring. So that tells you there's a lot of swelling typically in those adenoids. And the snoring indicates they're not getting as much oxygen into their body as they need. So they have hypoxia, which is very bad for tissue health. You need to get that oxygen up. So many doctors say, well, that snoring is so bad that it's causing other secondary problems, so we're taking them out.
When like you're a kid and say your parents secondhand smoke in the car or whatever, can that lead to having tonsil problems? Because
Yes.
those are a defense, right?
Yes.
It's growing up by strep throat, like literally every month.
Yes.
And they're like, oh, we don't know why, you're just a strep throat carrier. But my mom would like have her with this much crack and smoke like 5 cigarettes.
And it can lead to asthma, and it can lead to all kinds of long-term bronchitis problems and pneumonia problems in kids. There's just all kinds. Because remember, those kids, your lungs are still developing. Everything's still developing, and now you're overloading them with all these hundreds of chemicals that we don't even know. I mean, in cigarettes, for instance, there's cyanide. What is that doing to that child?
Well, is like being a strep carrier, is that like a real thing?
Yes. Just like what I just said to Josiah, is that what happens is your tonsils don't have the ability to totally fight off the bacteria. So they're always kind of hiding out there. And as soon as you're off the antibiotics, they come right back. And then you've got another infection.
And you said that some doctors say you grow out of that, though.
Yeah.
Does that happen? Or they just say that to make you feel better?
Sometimes it does. Sometimes it doesn't. So you just, these are decisions you have to like kind of make for your child and for yourself. And sometimes, it takes the stomping of the foot to get what you want, So you've got to keep those things in mind. All right, so now from the trachea, we're going to go into the bronchi. Now the trachea has C-shaped rings. Okay, because remember the esophagus sits behind that trachea. So we got the C-shaped ring with the esophagus behind. So when you eat things, okay, it's going to push into the trachea. The esophagus will push into the trachea instead of pushing backwards. Because what's behind the esophagus? Your spine, your spinal cord. So when you eat food, you've got to be able to push into the trachea instead of pushing backwards, because, you know, like, you could be swallowing food and it would, like, do this, you know, as it goes on down. It's, you know, stimulating your spinal cord, okay? But here's a problem. If I eat food and I don't chew it right and it gets pushed into the trachea, I can choke. This is what we call a cafe coronary. And you need to know this, okay? Because most people, when they choke on something, okay, now watch this for a second. When they choke on something, it gets stuck right about here. You've probably choked on something and it's probably gotten stuck right about here, which is right about where your heart sits. So you're sitting in a restaurant and somebody is choking and they do this, because this is where it's painful to them. And you, the medical professional, goes what? If I did this, you would think Heimlich? Or would you think heart attack? Because I'm gripping my chest because I'm in so much pain because the food is stuck right here. What I should be doing is indicate to you like this, that I'm choking. But of course I'm in so much pain I don't think, so I do this. So y'all are giving me CPR when I got a piece of food stuck in my throat and it just doesn't quite work. I need that food out of my throat because it goes into the trachea and now I can't breathe. And you know, that's a big problem. And so a lot of people will die from that because they have these cafe coronaries. So you have to be aware of that. Now those C-shaped rings turn into O-rings when we get into the bronchi. This helps to always keep them nice and open. And then the bronchi divide. So we got the primary divides to the secondary, and the secondary divides to the tertiary, and then the tertiary divides, and the bronchi just keep dividing and dividing and dividing until we get into these little teeny tiny tubes, which are called the bronchioles. Now, here's the difference I want you to know about the bronchioles. They don't have any cartilage around them. They just have smooth muscle. That smooth muscle, like all smooth muscle in our body, is extremely sensitive to epinephrine and norepinephrine. Epi and norepi do what to smooth muscle? Does it make smooth muscle contract or relax? Really? So we talked about blood pressure, and I said epi and norepi bind to the smooth muscles surrounding arteries. Do arteries get smaller or bigger? Smaller. So epi and norepi cause smooth muscle to contract. So we have some people, usually it starts in childhood, we have some people who will be extremely sensitive to normal levels of epi and norepi. And because of that, it will make their bronchioles smaller than they should be. And they have difficulty breathing. Now, it's a little bit easier to suck the air in and much harder to blow the air out. And so you'll hear these people breathing in very deep, but as they breathe out, they have this kind of wheezing type of noise as they breathe out. We call this asthma. And when these children or even adults with asthma, when they get stressed out, when they do a lot of types of different exercise, epi and norepi goes up, and when it does, it causes their bronchioles to constrict, and they have what we would call an asthma attack. Now, by the way, usually asthma does not occur or start in adults. I shouldn't say occur, but it usually doesn't start in adulthood. So you typically have asthma starting as a kid and grow up with asthma. And you don't get it in adulthood, usually. So if you have a patient who, let's say, is 25 years old, comes into the emergency room, and they have asthma-like symptoms, one of the things you should find out for them is how stressed out they are. The second is, have you had asthma all your life? And if they say, no, this is the first time I've ever had an asthma attack, they're probably a college student with a lot of stress in their lives, so that their epi and norepi levels are super duper high, which can cause you to have an asthma attack. You don't have asthma, you've just had a type of asthma attack. Yeah, April, question?
You said the bronchioles don't have...
They don't have any cartilage, they just have smooth muscle, the bronchioles. No cartilage, just smooth muscle. So they're controlled by epi and norepi. All right, so one other thing before we take another break I want to talk to you about is the membrane that surrounds the heart. Now, you know with membranes, we've got a couple layers. We have visceral membranes and we have pleural membranes. And in this case, parietal. Visceral membranes and parietal membranes. And in this case, the visceral membrane is the visceral pleura, and it is directly on the lungs, right? Attached to the lungs. If you tried to pull this pleural membrane off, you'd rip lung tissue off with it. It's so sealed. Now, then we also have the parietal pleura. Where is that attached? Say it again?
On the visceral.
On the visceral pleura?
No, it's on the cavity.
It's on the cavity? You're all right. You're correct. But I want to kind of get this in your mind so that you understand it is on the visceral pleura and it's on the cavity. Okay? It's the both. And this is really an important concept. So let's go back to the fetal stage of development. Baby's inside mom. Baby is not breathing. It's just a little fish swimming around in water. Okay? And one of the things, if you could look at this fetus, is that its chest is not out. Its chest is actually a little caved in. Okay? Because they haven't taken their first breath. And that's what kind of pops the chest out, is with that first breath. All right, so now you have inside, you have the lungs. So let's say these are the lungs. And then directly on top of the lungs, you have the visceral pleura, right attached to the lungs. Now, attached directly to the visceral pleura is the parietal pleura. They are attached to each other. Now, the lung cavity is caved in. So guess what? Right attached to the parietal pleura is the lung cavity. So you have the lungs with the visceral pleura on top, the parietal pleura on top of that, and then the chest cavity right on top of that. They're all on top of each other. Okay? So if this is the lung, you have the visceral pleura right on top. And then attached directly on top of this, directly on top, is the parietal pleura. And then directly on top of this, let's see the best way to do this. I'll just follow it across. Is the thoracic wall. So they're right on top of each other, stacked right on top of each other. But now, the way that they're situated, because the cage is bent in, it's like this, okay? And they're all stacked right on top of each other. Now, this baby's going to be born, and the second the baby's born, he or she is going to take their very first breath. Now, all these membranes are attached to each other, and the baby takes his first breath and is going to fill the lungs up. Okay, now watch what happens as the lungs fill up with air. Everything rises out. Everything now pulls out. So your lungs, okay, depending on how thick your pectoral muscles are, but underneath your pectoral muscles, directly attached to the thoracic wall, are your lungs. They are right there, okay? So if you don't have really thick pectoral muscles and you were to put like a probe right through, you wouldn't have to go more than 1/4 of an inch through the wall to get to your lungs. They are right underneath. And what happens is because these membranes are attached to the wall of the thoracic cavity, they hold the lungs open. If you cut all those membranes off of the wall of the thoracic cavity, the lungs would collapse. But because the membranes are attached to the lungs and attached to the thoracic cavity, it holds the lungs open. And of course, they're attached all the way around, in the front, on the sides, in the back. And this is what is holding your lungs open. So for instance, if you have a patient who comes in and they've been stabbed and some of these pleural membranes have been torn, you could have a collapsed lung. Now the nice thing is our lungs are built in such a way that even though we've got like 3 lobes over here and 2 lobes over here, these lobes are actually separated. They're not full lobes. There are little segments in between. And each lung is separated into about 23 different segments. So if your patient is stabbed in the upper segment and the pleural membranes tear, only that upper segment will collapse. The rest of the lung will stay open. Anytime membranes tear, so for instance, you could even have a patient who has pneumonia and they're coughing really, really hard. That could make their membranes tear and that area of the lung could collapse. If an area of the lung collapses, we have what's referred to as a pneumothorax. Now they're pretty easy to fix, okay? All you're gonna do is you're gonna treat them kind of like a balloon. You're gonna put a tube in there, you're gonna fill them up with air, and then all those membranes are very, very sticky, so the minute you fill that lung with air, it'll stick right to the wall of the thoracic cage again. Now if there's a hole from the outside, you gotta patch it up so that the air can't leak. If there's not, you just have to go in and fill that segment of the lung with more air, and it will stick immediately to the wall of the thoracic cage and the lung will stay open.
Is pleurisy when the lining of the membranes rips?
No. Pleurisy, okay, so in between the visceral and the parietal pleura, there's a little bit of fluid, okay? And it's a thick fluid, kind of like the consistency of egg whites. It's a little thicker. And so as you're breathing, those 2 membranes rub on each other. And you know, if you do this all day long, 18 times per minute, you're gonna have a lot of friction and it's gonna burn. So we put a little oily substance in between so the visceral and parietal can rub on each other without problem. But sometimes people will get viruses, bacterial infection, even an autoimmune disease called lupus, where they don't make enough of this fluid, what they call serous fluid. It goes away. And so when you breathe, now those 2 membranes rub on each other. The person gets a lot of friction, and with every breath, it's hot and painful. But typically, most often, pleurisy is due to some kind of infection, viral or bacterial. Any other questions? Yeah.
So when the lungs collapse, does that portion that actually collapsed, it no longer functions?
Yes.
At what point does that portion of lung not
Ever function again?
irreplaceable?
Well, you know, you're probably going to come in pretty quick when something like that happens. But I would guess if you let it go for more than a couple of weeks, you're not going to be able to fix it. Because you're going to get connective tissue growing in there and alveoli collapse. So probably need that person to be in there right away. And it's very painful. It's not something you want to deal with. So most people will go in and have it cared for. These little grape-like structures at the end of our bronchioles. The alveoli are where gas exchange occurs, okay? So important to know about the alveoli. They are surrounded with capillaries. And we're going to exchange gas between the alveoli and the bloodstream. So oxygen is going to leave the alveoli, go into the blood. And then carbon dioxide, which is that waste product that we make in glycolysis and Krebs, all that kind of stuff, that's going to leave the blood and go into the lungs so we can exhale. Now, one other thing I want you to just notice, we're going to talk about this a little bit later, but I want you to take notice to the fact that there is also a whole lot of elastic connective tissue surrounding each individual alveoli. So that's going to be a little bit later on, that's going to be very important about what we're talking about. But for now, okay, so let's say that this is our single alveoli, okay? And then we have capillaries surrounding these alveoli. Now what I'm going to do is I'm going to draw them in 2 different colors. And these colors are going to represent how much oxygen is going to be found in the blood. So if it's blue, this is going to have less oxygen in the blood. If it's red, it's going to have more oxygen. So typically, if our red blood cells are low in oxygen, it's our deoxygenated blood, we would say this is the venous side of the capillary. And then this would be the arterial side, because now the blood is actually oxygenated. So this blood that's coming through here, this is coming from the right side of the heart. And then once it picks up its supply of oxygen, and then dumps off its carbon dioxide load, this blood is then going to the left atrium. Now, oxygen and carbon dioxide, as they are leaving and entering this alveoli, they're just moving by simple diffusion. So oxygen moves from simple diffusion from the alveoli to the blood, and CO2 simple diffusion from the blood to the alveoli. Now there is a space right here in between our alveoli and our capillary. It's a very small space. I make it look like it's huge, but it's a very, very small space. It's probably only about 10 angstroms between the alveoli to the capillary. Now we've talked about angstroms before, so you know angstroms really, really tiny. So these guys, these capillaries, are just about touching the alveoli. This space in between the alveoli and the capillary is typically referred to as the alveolar space. That space can't be too big. It has to be really, really small, because you don't want a big distance between the capillary and the alveoli, because oxygen and CO2 can't travel too far. And so you've got to have these guys right next to each other. Also, there's a little tiny bit of liquid in this space. That's okay. Oxygen and CO2 can travel through that liquid. But what if we have a patient who, let's say, has pneumonia? And now they're building up fluid in their lungs. And some of this fluid is sticky fluid because we've got bacteria building up in there and white blood cells trying to fight it, and we make a lot of mucus in there. And we get this sticky fluid that seeps into this alveolar space. And what it does is it starts pushing the alveoli and the capillaries away from each other, far enough that oxygen and CO2 can't diffuse in and out of the lungs and the blood. And now your patient dies from not being able to exchange gases. So that buildup of fluid in that alveolar space, big, big problem. Also, if we look at the wall of the alveoli, oh, I'm sorry, go ahead, April, first.
I just wanted to know, is that also known as the respiratory space?
Yes,
Oh.
yes. So it could be alveolar space, it could be respiratory space. Depends on who you're talking to or where you're reading. So yes, thank you. Good question. Okay? So, the wall of the alveoli are alveolar or respiratory space, and then the wall of the capillary. These three things: wall of the alveoli, our space, and then the wall of the capillary. All three of these together are referred to as the respiratory membrane. So again, wall of the alveoli, the space in between, wall of the capillary. This is the respiratory membrane. And all three of them have to be perfectly healthy. All three of them have to be functioning right, or all three of them have to be intact in order for good respiration to take place. So let's say we have a person who is smoking a lot of cigarettes over a long period of time. Don't ask me how much a lot or how long it is. It has to do with what they're smoking and their genetics, all that kind of stuff. But they're smoking a lot of cigarettes for many, many years, and they're paralyzing their cilia continuously. And as they're paralyzing their cilia, stuff is going down into the lungs, into the alveoli. And it's the debris and it's mucus. Eventually, if we keep paralyzing our cilia, eventually they will die. Now you can tell when somebody's cilia has died because they get that smoker's cough, you know, that cough where they sound like they're hacking up a lung, okay? They're coughing so hard. That's because all this garbage is now getting down into the lungs and you can't stop it. Nothing comes back up. What will eventually happen is, remember now, our alveoli are thinner than tissue paper. And you start building up this extra mucus and all this other dust and particles in there. What would happen to tissue paper if you put all that stuff on top of it? It would tear, it'd disintegrate. So does the wall of the alveoli. And eventually, this wall has the potential to disintegrate. Now, if oxygen comes in, so oxygen moves in, it is so far away from the blood that instead of getting into the blood, it just sort of diffuses out in any direction and the person can't pick it up in the bloodstream. And so you don't get diffusion in. So that wall of that alveoli has to remain intact for us to be able to get oxygen in and out of the system. We also have to make sure that this little respiratory space, our alveolar space, is very small. Don't accumulate any fluid or mucus in there or you can't exchange gases. And if you have any kind of block or damage to the capillary, you won't be able to exchange gases. So when they say the resting membrane has to be, or respiratory membrane has to be intact, that means the wall of the alveoli, the space, and the capillary all have to be working perfectly or you can't exchange gases. This is a problem. And breaking down that alveolar wall is pretty easy to do if we keep sending all kinds of junk down into the lungs. Now, by the way, all of us, okay, are going to lose some alveoli as we get older. It happens. It's natural. All of us, to some extent, as we get older, will have a little bit of what we call emphysema, which is losing the alveoli. You're destroying the walls of the alveoli. Everybody gets it. You just won't be super sick from it like other people will. They will get it much worse. You'll just have a few alveoli that you lose, not a whole bunch. But here's my advice to you, okay? If anything else you've ever heard in your life, any kind of advice, this is more important advice than any of it, okay? So listen close. Don't get old. It sucks. Okay, so stop right now. Don't do it. Done, okay? I'm telling you, it's the best advice you'll ever get.
So what about people that quit smoking? Is there a chance to rebuild that?
Ah, good question. Yes and no. Even if you have a person who's been smoking for, let's say, 30, 40 years, okay? When they quit, they will stop building up all that nasty mucus and particles in their lungs. Some of it will be able to be cleaned out over time. And within the first, like, say, 6 months of them stopping smoking, they will tell you that they feel better. Now, will they ever be totally okay again? No. But can it get better? Yes, absolutely. Can alveoli rebuild? No.
So I quit smoking like 4 or 5 years ago. It's been 4 years ago. My lungs will never come back to 100%.
No, but neither will any of ours. The rest of us in here don't have 100% either. We're alive. Everybody's lungs deteriorates over time. Everybody's. So the fact that you stopped I'm sure you feel a lot better as far as breathing, and so your lungs have healed to some extent. Will they ever be as perfect as when you were 10? No.
I got really sick right after I quit smoking.
Oh,
Is that
very,
normal?
very common. Very common. Yeah, because your whole body tries to compensate around the smoking, and then when you take that all away, now it's got to figure out how to get back to normal homeostasis again. So super common. Yeah, the immune system's all messed up, and yeah. And you know, if you're quitting smoking, if you can get through the first 2 weeks, you'll make it. But it's those first 2 weeks that are just, they're going to kill you and you're going to kill somebody else. You know, it's that kind of thing. Now, inside the alveoli, there are a couple other cells that are helping us out. One of those cells, I think this is kind of an interesting thing, we call them dust cells. That's their actual official name. But these are just phagocytes. And so in case stuff does get into our lungs and we haven't been able to catch it all, here's another mechanism to keep us from, you know, getting this emphysema. We've got all these little dust cells cruising around eating up all the dirt. Their job is to like vacuum up the inside of those alveoli, which is really nice. Other type of cell that we have inside the alveoli is called a type 2 cell. Okay? Type 2 cells secrete a very important chemical. This chemical is surfactant. The job of surfactant is to decrease surface tension in the alveoli. Okay, so now I'm going to take you back to the first weeks of school. In those first weeks, we talked about surface tension. So do you remember when we talked about those 2 glass slides, and you put a little bit of water in between those 2 glass slides, and those 2 glass slides can stick together, and you can't break them apart very easily because of surface tension. And then I told you on the inside of our alveoli, we have proteins that, like our glass slides, create a negative charge. You remember this? And then inside, because we're humidifying the air that we breathe, we're bringing water with our air into our lungs. You bring this water in, and it has the slightly positive, slightly negative thing going on, and the water can bind to the walls. And what this water can do is grab a hold of the walls of the alveoli and suck those walls in, cause that alveoli to implode. And it sucks it in so tight that no matter how deep you breathe, you can't blow this back up. Once it gets sucked in, that's it. You and I don't have the ability to blow it back up. But now, obviously, we don't have any problem with our alveoli because we were born making surfactant. And what surfactant does is it's an oil that coats the walls of the alveoli, covering over all the negative charges, preventing the water from binding. And so when water gets into our alveoli, just like if you drop water onto oil in your cooking pan, it just sort of balls up. The water balls up around the edge of the alveoli, and then we exhale that water. And now our alveoli won't implode. But sometimes babies are born premature. And type 2 cells cannot start making surfactant until around the 8th month of pregnancy. And the reason is that type 2 cells require a certain hormone to stimulate them in order to get these cells mature enough to start making surfactant. Now that hormone you are well aware of. This hormone is cortisol. And a fetus doesn't really make much cortisol until around the 8th month of pregnancy. And you don't want a fetus to be making a lot of cortisol until then because cortisol can be catabolic. So you got this little baby that's trying to build, and you don't want a hormone that potentially can tear things down. This is also why you don't want mom to be super stressed while she's pregnant. Okay? Because if mom is super stressed while she's pregnant, she's producing lots of cortisol, which is a steroid hormone, that goes right through the uterus, right into baby's blood, and now baby has as high stress levels as mom does. And that cortisol goes into baby and makes all kinds of changes prematurely in that child, and those babies can be born with some problems. The problems that cortisol produces. An immune system problem, and we can go all those problems that you had to list for cortisol being too high. Babies can be born with all those problems if mom is stressed out. This can also potentially happen if baby's going to be born premature. So for instance, it's pretty well known that if a mom has one premature baby, there's a high probability she'll have another. Now, it's not 100%, but you got to be aware that it's a possibility. So mom has one preemie, so what you're going to do is make sure that this preemie doesn't, when it's born early, doesn't have any respiratory problems. And so what you're going to do is start injecting mom around the 4th month of pregnancy. You're going to start injecting her with cortisol. Mom's going to come in once a month, and you're going to give her cortisol injections. And then around the 8th month, you're going to bring her in every couple weeks and give her cortisol injections. Which also means that you are causing type 2 cells to mature early, so that the type 2 cells can make surfactant early, so that when the baby's born early, they won't have any respiratory problems. And the alveoli will open up when they take their first breath instead of get stuck together. It's the #1 cause of premature death, when those babies are born early, that their alveoli are stuck together. You'll try in the hospital to put tubes down the baby's throat and drip surfactant in there, hoping you'll pop some alveoli open. Sometimes it works. Most of the time it doesn't. Babies born early, this will be the #1 cause of their death. And so what you want to do is, if you give cortisol to mom early, baby will make surfactant early, and baby will not have respiratory distress when they're born. But because you've given baby such a high level of cortisol, they may have other problems. They're going to be really cranky. They may have a lifetime of immune system problems. They may have other deficiencies because cortisol was so high. Of course, a lot of people say, well, then why do we do that? Well, if you don't do that, baby dies. If you do it, baby lives, but baby's going to have some problems. They're not going to be like mentally retarded, but they may get sick easier, okay? Or they may have more ear infections than they normally would. Or they may later on develop an autoimmune disease. Or, you know, we don't know what's going to happen. But the baby's going to live, you know, and live a normal life. But just probably have to be a little careful. Now, the problem is, most of the time when we do this and give these cortisol injections, we don't explain to the parents, your baby may be a little crankier than most because they're not exactly the healthiest child coming out, and parents aren't exactly totally prepared. I'm not sure a lot of doctors are totally prepared and realize what all these high levels of cortisol potentially could do to this child, especially in the short term and the long term. So when you have a mom come in and say, my baby's crying all the time, she seems so stressed out. Well, probably because all her life she's going to be very easily stressed because she's had these high levels of cortisol. Now she's super sensitive to stress. So little things like that will just, you know, help the parents along the way to be a little more wise in how to be able to deal with their child. So important for you to know that too. Okay, so right now where you're sitting, where I'm standing, all the way around you is a column of air. And this column of air goes all the way to the top of our atmosphere. And so you have this tremendous column of air that is pressing down on you. Now, it must not be pressing down too hard because I don't feel like I'm, heavy or anything like that. But it is pressing down on us. Now, in this column of air are basically 3 types of gases: nitrogen, oxygen, carbon dioxide. Nitrogen is the most abundant. We have about 78% of our air is made out of nitrogen. And then about 20, give or take, percent oxygen, and then about 1% CO2. Now, if you live in Fontana, I can't tell you what the percentages are because there's so much smog and, arsenic and whatever. But this is your typical percentage. Whether you're here at VVC, you're down, let's say, at Loma Linda area, or you're up on Mount Everest, the percentages don't change. 78% on Mount Everest of nitrogen, 21% oxygen, 1% CO2, which is weird because you wouldn't think it would be the same, since if I'm standing here, I'm standing at Loma Linda, I don't have very much problem breathing, but if I'm on top of Mount Everest, I do a lot of problem breathing. So it must not be the percentages that give us the problem with breathing. Instead, it has to do with the pressure. Now, anytime molecules of air hit on you, okay, or hit on something, they create a force. That force is what we call pressure. Now, they're hitting on us, but it's really light, so the pressure is not that big of a deal. But we'll go with Loma Linda. The reason I say that is because Loma Linda is at what we would call sea level. So we're about, give or take, 3,000 feet above sea level. Okay, so Loma Linda is at sea level. If we were to measure the pressure of air at sea level, okay, so at sea level, so at Loma Linda, the pressure of air is 760 millimeters of mercury. Okay, so let's talk about what the heck that means, because that's really important for you to know. So there's this Italian scientist. His name was Dr. Torricelli, and he was, for whatever reason, all into pressures in the air. And he was studying this, and he came up with this really cool little device, okay? Very simple device. And what he did is he made this really long glass test tube, okay? And so it was open at one end. And he took this long glass test tube and he put it into this bowl, okay? And he filled this bowl up with liquid nitrogen. Okay? So he sunk the test tube into this liquid nitrogen. Now, by the way, he measured this test tube and he marked it off in millimeters all the way up the test tube. So he knew how tall the test tube was. And he puts this liquid nitrogen in this bowl, sticks the test tube upside down in the liquid nitrogen. And what he was measuring is how hard does the air push down on the liquid nitrogen to cause that liquid nitrogen to go up the test tube. And it was different depending on the altitude. If he was standing at sea level, it went up 760 millimeters. Because if I'm standing at sea level, the column of air is much bigger than if I'm standing on Mount Everest, which is 29,000 feet above sea level. The column of air is much smaller. So the bigger the column of air, the more molecules will be pressing down on that mercury, causing it to go up the test tube. And so at sea level, it went up 760 millimeters. Now, Dr. Torricelli didn't do this, but other scientists have taken this handy-dandy little instrument to the top of Mount Everest to see how much the column of air pushes down. And in this case, it only goes up about 153 millimeters. So if I'm standing at sea level, I say the atmospheric pressure, or the pressure in the atmosphere, is 760 millimeters of mercury. If I'm standing on Mount Everest, it's 153 millimeters of mercury. And what it's doing is the column of air is pressing on my body. And this pressure has a lot to do with how well I can breathe or not. So on Mount Everest, my pressure is about 153 millimeters of mercury. All right, now, oxygen simply diffuses from our lungs into the blood. Goes from high concentration to low concentration. Real simple. But I want to tell you that when we're talking about a gas, we usually don't call it concentration. We call it pressure. It's the exact same thing, but we use the word pressure. So oxygen, when I say it diffuses from the alveoli into the blood, instead of saying it goes from high concentration to low concentration, I would say it goes from high pressure to low pressure. Same exact thing. But oxygen is going to move high pressure in the alveoli to low pressure in the blood. It's going to do the same thing. It's going to move from high pressure in the air to lower pressure in my lungs. The higher the pressure of oxygen in the air, the easier it will be for me to get into my lungs. Okay, now watch. How can I tell what the pressure of oxygen is in the air? Well, if I'm at sea level, I take the pressure in the atmosphere, 760, and then I multiply it with the percent of oxygen. And that gives me somewhere around 160 millimeters of mercury. Pressure just for oxygen. Now watch this. If I'm on Mount Everest and I want to see what the pressure of oxygen is in the air on Mount Everest, it's a heck of a lot lower. So because the pressure of oxygen in the air is so low, I have a real hard time doing simple diffusion. I have a hard time with oxygen diffusing from my alveoli into my blood. The lower the pressure of oxygen in the air, the harder it is for it to diffuse into my blood, even though the percentage is exactly the same. No matter if I'm at Loma Linda or I'm on Mount Everest, I have the same percentage of oxygen. But because the pressure is so much lower on Mount Everest and oxygen moves from high pressure to low pressure, it's very hard for oxygen to get into my blood. Now the weird thing is, I don't know if you've ever, oh go ahead, I'm sorry.
So some people so basically athletes, they train to have
I was just going to talk about that. Just going to talk about that. So let's go there. That's a great question. So I don't know if you've ever seen any of like these special shows on television where people are climbing Mount Everest, okay? And one of the things that I find really interesting is these guys who are super trained athletes, okay? They are climbing to Mount Everest and you watch them as they climb and they're just like moving like everything is made out of lead. And it takes them so long. I mean, minutes, literally. I'm going too fast to move 1 foot. I was watching one, this is a long time ago, and some guy was talking to the other guy and saying, we got to go back down. We don't have enough time. There's only 5 hours left before it gets dark. And they were less than 500 feet from the top. But they had to go down. They never made it to the top because it would have taken them longer than 5 hours to get to the top. That's crazy. Why are they moving so slow? Not enough oxygen, therefore they don't have enough ATP. They don't have enough energy. But then, here's the funny thing. So these guys are moving like they're made out of lead, and there's this Sherpa who runs up ahead of them to pick something up on the top and runs back down. You can see the guy running in the TV show. How the heck is he doing that when these other very well-trained athletes are walking like their legs are made out of lead? Well, a Sherpa is somebody who lives in Nepal naturally, and they typically live at 20,000 feet above sea level. And we learned this the other day in blood pressure. When the oxygen supply is low in your blood, you make erythropoietin, which helps you to make more red blood cells. The more red blood cells I have, the more oxygen I can carry. These Sherpas have so many red blood cells Their blood is like, thick chocolate. It's super, super thick. Tremendous amounts of red blood cells. Therefore, they can carry lots and lots of oxygen. So for them, it's just like running up a hill. They do it all the time, every day. Get paid lots of money to carry all these people's equipment up and down the hill. So, oops, I left something on Everest. So let me run up and get it. And literally, that's what they're doing. And they're not out of breath because they have so many red blood cells, they can carry so much oxygen. But here's a problem for them. They've lived up there all their life, and they can never, ever come down to sea level. Because once your blood gets that thick, and it's been like that all your life, your heart has to pump that thick stuff. It's like sludge. It's got to pump it. So the heart has to become really strong. It gets much bigger and it becomes much stronger. So what would happen if these people came to live down at sea level? Plenty of oxygen in the air. Don't need as many red blood cells. I won't make as much erythropoietin, and my blood cells will die off in time, and my blood will become super thin. But my heart will still be very strong. And my blood is so thin and my heart is pumping so strong that my blood pressure goes up and I start popping capillaries all over the place and die. So if they are born and raised at super high sea level like that, their heart is so strong, their body can't handle coming back to sea level. But now athletes who they go and practice at sea level, they're doing something called legal blood doping. Now, illegal blood doping used to be, I can take blood from my own body, I'll have it put in a refrigerator for a while, and right before I go do a sport, I'll inject more blood into me. Because the more blood I have right before I do the sport, the more oxygen I can carry, the more ATP I can make, and it makes a big difference. And a lot of people used to do blood doping before they did a sport. Now, the reason that that's illegal is because the more blood you put in the bloodstream, the higher your blood pressure also. And then you go to do this sport, which also raises your blood pressure, and now these athletes were killing themselves. And so they said, no blood doping. So then athletes decided they'd get around it. So now they all practice like in places like Big Bear. Because if you can go and stay at a place that is 8,000 feet or above, there's not as much oxygen pressure. And you'll start making more red blood cells naturally. You'll carry more oxygen. So when you come down to sea level, you have more ATP. But you still have the heart problem. You still have that heart problem. You still have the high blood pressure. They don't care. Winning is everything. They don't care if they kill themselves.
Was that why sometimes when people go to Big Bear or Arrowhead or whatever, and they've lived through their whole life, they come back and they're like sick?
Yeah, because it's a higher altitude.
Well, my friend goes and then she comes back and she's like sick for 2 days, like exhausted, like
Yeah.
she just can't function.
Yes, because she's been doing a lot of things on very low oxygen levels. And so you lose ATP, and it can make you very sick, very tired. And some people are really sensitive to it also.
No wonder. I went to Oktoberfest in Big Bear and got trashed. Just off a few beers.
Yes, because you have less oxygen. You have less oxygen, and so the alcohol does affect you more.
No wonder.
That's why everybody likes Oktoberfest in Big Bear or Arrowhead. It's all about the less oxygen levels.
Pork thrown under the bus. That's what he gets for helping you.
Okay, so we're going to talk about external and internal respiration. External respiration would be inhaling, exhaling. And then internal respiration is what happens with exchange of gases between the blood and the lungs, and between the blood and the tissues. Okay? So we're going to start out with inhaling. So when you breathe, it's a little bit different from your heart beating, because your heart is beating like 72, 80 beats per minute. You're not breathing that fast. You're breathing somewhere about maybe 16, 18 breaths per minute, which means when we breathe, we inhale, rest, exhale, rest. So you're inhaling, and then you're exhaling. And you don't just inhale, exhale, inhale, exhale. So what we're going to say is our person, as we start, has inhaled and then exhaled. And after they exhale, we're at rest. Okay? So we're starting, they've exhaled and we're at rest. So when the lungs are at rest, the pressure inside the lungs is equal to the pressure in the atmosphere. Now, anytime we talk about the pressure inside the lungs, we're going to call this intra, because intra means inside, intrapulmonary pressure. So we've inhaled and then we've exhaled and we're at rest. And the pressure inside the lungs is the same as the pressure in the atmosphere. Now, it doesn't matter where you are on the face of the planet. If you're standing at Loma Linda or if you're standing on Mount Everest, the pressure is going to be the same. So if I'm at Loma Linda, the pressure is 760 millimeters of mercury. If I'm on Mount Everest, the pressure is 153 millimeters of mercury inside my lungs as well as in the atmosphere. Okay? So now I'm at rest. Oxygen levels in the blood are falling because that oxygen is going from the blood into the tissues so I can make ATP. And CO2 levels are rising. So I'm going through glycolysis, citric acid cycle, I'm making CO2. That CO2 is leaving the tissues, getting into the blood. So O2 levels are dropping, CO2 levels are rising. We have specialized neurons, specialized receptors that are constantly monitoring oxygen and CO2 levels, just like we talked about the ones in the kidneys the other day. These are called chemoreceptors. So when O2 levels fall and CO2 levels rise, these guys are going to be stimulated. They're going to go on red alert. Okay, so we have central chemoreceptors. And these central chemoreceptors are in the medulla oblongata. And these central chemoreceptors are going to be stimulated when CO2 levels change. The CO2 levels are going up. The peripheral chemoreceptors are for oxygen. These guys are found in the carotid arteries. And when oxygen levels start to drop, the peripheral chemoreceptors are going to be stimulated. Now, since we have two different types of chemoreceptors, real important in respiration, there can't be any competition. So if the peripheral say to do one thing and the central say to do something else, it is always the central that's going to win. So the central chemoreceptors are in charge. And they're going to tell the body exactly what to do, even if the peripheral says, no, 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 I think we should do the opposite. Doesn't matter. The body's always going to listen to the central chemoreceptors first and foremost. So these chemoreceptors are going to be stimulated. The chemoreceptor's job is to turn on the respiratory center in the medulla oblongata. And when this respiratory center is stimulated, it then stimulates the phrenic nerve. Now, hopefully you remember from dissecting your cats, you have that phrenic nerve that spreads out all through the thoracic muscles. So that phrenic nerve is going through the thoracic muscles, and then also it's going to the diaphragm, okay? And the job of the phrenic nerve is to make all those thoracic muscles contract. And when those muscles contract, the thoracic cage moves out and up. And then the diaphragm, you remember, is that little bell-shaped muscle that separates thoracic from abdominal area. And when the diaphragm contracts, it contracts down, okay? So again, we're going to have the phrenic nerve stimulating the thoracic muscles, and that's going to move our thoracic cage out and up. And then we're also going to stimulate the diaphragm, and this is going to cause the diaphragm to contract down. Okay, now we already talked about this a little bit ago. And remember I told you that the pleural membranes, the visceral pleura is attached to the lungs, and then the parietal pleura is right on top of that. And then that parietal pleura is attached to the thoracic wall, also attached to the diaphragm. So what's going to happen to my lungs when the thoracic cage moves out and up? My lungs are attached to this thoracic cage, aren't they? So when my cage moves out and up, what's going to happen to my lungs? They're going to be pulled out. They're going to expand. And what's going to happen to my lungs if my diaphragm contracts down? It's going to pull my lungs down, right? So my lungs are going to be pulled out, and they're also going to be stretched down. What's going to happen to the volume of my lungs? If I stretch them out, In both directions, I stretch my lungs out in this direction, I stretch my lungs out in this direction. What happens to the volume of my lungs? They get bigger. Exactly. Okay, now, super important. When we talk about pressure, and we're looking at a container, like your lungs, but any container, doesn't matter. You're looking at a container, and you've got gas in that container. If you make that container bigger, the pressure will go down inside the container. If I make the container smaller, the pressure will go up inside the container. I always like to give the example of, let's say that I have a cage. It's not a very big cage, just a kind of a small cage like this, and maybe like 2 feet by 2 feet cage, okay? And I put into my cage 2 adult rats. Now, they're probably going to be okay, 2 rats in a 2 foot by 2 foot cage. But what if I keep my cage 2 feet by 2 feet and I put into my cage 20 adult rats? Is there going to be a little pressure in that cage? Yeah, they're not going to be real happy with each other because they're like banging against each other and banging against the walls, and there's not a lot of room. Now, what would happen if I took my 2 foot by 2 foot cage with my 20 rats and I made it a 200 by 200 foot cage? What happens to the pressure inside that cage? It goes down. My rats are happy. They all go to their own little corner and they just live there all by themselves. By the way, if I keep my rats in a 2 foot by 2 foot cage, eventually pressure will go down too because rats will eat each other. We're just kind of like humans. If we all get like too crowded with each other, we just eat each other. It's sort of the same thing. Or we just kill each other. Either way. So, same thing with our lungs. You've got this air, kind of like the rats in there. You've got this air in your lungs. When the container is smaller, everything's kind of bouncing on each other, okay? It's squished in there. If I spread the container out, I increase the volume, the pressure inside goes down. And so that's what's going to happen with our lungs. We just increase the volume and we just drop the pressure. Now, I'm not going to write a whole bunch about membranes, but you need to explain about the membranes in this step. Okay, so the phrenic nerve is causing these muscles to contract. And when the thoracic muscles and the diaphragm contract, this pulls, by way of the membranes, on our lungs. Causes the lungs to stretch out. The volume of the lungs gets bigger, which means the pressure inside the lungs drop. Now, if I just take a normal inhalation, I'm not really like stretching my chest out very much. It's just a little tiny bit. So I'll only stretch my lungs out a little tiny bit. So pressure will only change or drop about maybe 4 millimeters of mercury. But what if I want to take a really deep breath? I'm stretching my lungs way far out. Pressure would drop more. So in a normal inhalation, I'm only going to drop about 4 millimeters of mercury. Now, if I say I started at 760, now I'm about at 756. Okay. So, most people believe that when you inhale, what you're doing is you're sucking air in. Okay? That is not at all what happens when we inhale. Okay? So now remember, we've got this column of air all around us. And this column of air is creating a pressure. And let's pretend we're at sea level and say the pressure is 760 millimeters of mercury. So I have this pressure of 760 in the air. And I have just stretched my lungs out. And the pressure inside my lungs right now is 756. The pressure in the atmosphere is higher than the pressure inside my lungs. And air moves from a high pressure to a low pressure. So that column of air with the pressure of 760 will literally push air up my nose, down my throat, and into my lungs until equilibrium. And that's how I inhale. I do not suck air in. It is literally pushed into my body. Kind of like how our vacuum cleaner works. You turn on a vacuum cleaner, and the first thing the engine does is that motor drops the pressure inside your vacuum cleaner. Now the pressure outside is higher than the pressure inside, and the column of air is pushing into your vacuum cleaner. Now that little roll brush thing that's on the end helps to get the dirt up, so it gets pushed in with the vacuum cleaner. The lower you drop the pressure, the more suction, as we call it, will happen. But the lower you drop the pressure in your vacuum cleaner, the more the column of air will push air into your vacuum cleaner. You do not suck air in. It doesn't happen. There is actually no such thing as a vacuum the way that you think it works. It is literally the column of air pushing air into the body. So again, pressure in the atmosphere is higher at 760 than pressure inside our lungs. And air is going to move from high pressure to low pressure until we reach equilibrium. So you're going to move approximately 300 milliliters of air into the lungs to fill that container up. And eventually it will hit 760. So you'll have 760 in the lungs, 760 in the atmosphere. So you just inhaled and came to rest. And anytime you're at rest, whether you inhale and rest or exhale and rest, at rest, the pressure in your lungs will equal the pressure in the atmosphere. And that's the end of inhaling. Any questions? We're good? Okay.
Thank you. Speaking of tequila, that song just came up in my head.
Okay, so again, we just inhaled about 300 milliliters of air, and we're at rest. So the pressure inside the lungs, intrapulmonary pressure, is equal to atmospheric pressure. So in the lung tissue itself, we have what are called stretch receptors. And these stretch receptors obviously are stimulated by the lungs stretching out. When they fill with air, these stretch receptors are going to be responsive. They're going to turn on. And they're going to send information to the respiratory center in the medulla oblongata. And what we're going to see happen is that once the stretch receptors talk to the medulla oblongata, they're going to tell the medulla, hey, look, I need you to turn off the phrenic nerve. They're not inhaling anymore. We don't need to keep moving those respiratory muscles. Turn them off. And when the phrenic nerve turns off, the respiratory muscles relax. So this is when I get to play with my slinky. All right, so remember I told you, super important concept, okay? A little bit difficult to understand. But in the lungs, there's a lot of elastic connective tissue. They're very stretchy, kind of like the slinky, okay? So if we can pretend the lungs are the slinky, and then my hands are going to be the respiratory muscles, because my lungs are attached to the respiratory muscles. So when my respiratory muscles contract, it expands the thoracic cage outward, right? Okay? Now, this is, we want the lungs to go back to their regular size once we're done with this whole thing. So once we inhale, we're stretching the lungs out. Once we're done with the whole thing, we want the lungs to go back to the regular size, all right? But this is what does not happen to get the lungs back to their regular size. Does not happen. So I've stretched them out with the respiratory muscles. To get the lungs back to the regular size, I do not use the respiratory muscles to push them back. Don't do that. Instead, what happens is when I stretch the lungs out with the respiratory muscles, and I tell the respiratory muscles, okay, I want you to relax now. When the respiratory muscles relax, it's the elasticity of the lungs that actually pull the respiratory muscles back. Okay, so let me say that again. So respiratory muscles, like my hands, they're told, pull the lungs out, stretch them out so we can fill them with more air. Then we tell the respiratory muscles, hey, look, just relax. Turn off the phrenic nerve. You guys just relax. The way that the lungs get back to their original shape is they're so stretchy that they immediately start pulling back. Well, it just so happens they also pull the respiratory muscles back with them. The respiratory muscles do not push the lungs back. The lungs actually pull the respiratory muscles back as well. Now, you know in that disease emphysema that we talked about already where the alveoli can get destroyed because you get too much mucus, too much particulate matter in the lungs. The other thing that can get destroyed is the elastic connective tissue. And instead of your lungs being real stretchy like this, your lungs just kind of stretch out. And there's not a lot of recoil, not a lot of ability to pull it back. So this elastic connective tissue gets all destroyed, and my muscles can still pull the lungs out. But can my lungs pull my muscles back very well? They can't. And so what we see with people who have emphysema is over time, their muscles just keep pulling the lungs out more and more and more, but the lungs lose their stretchiness and they can't pull the muscles back as much. And they get these really rounded chests. They get what we call a barreled chest because their muscles just keep pulling and pulling and pulling, and the lungs never pull those muscles back. And the lungs get huge inside because they're all pulled out. They're all totally stretched out. And the chest is going around it to try to keep pulling that lung out. But we can't pull the muscle back. And we have to be able to have this stretchiness. We have to be able to pull the lungs back to their regular size and have the muscles follow to be able to inhale the next time as good as we need it to. And also to be able to exhale. If we can't pull the lungs back, get them to their regular small size, exhaling won't occur because we won't be able to change pressures appropriately, okay? So the lungs have this elastic connective tissue, and they are able to recoil, pull themselves back to their original smaller size. Keep in mind, we started this whole thing off with 300 extra milliliters of air. And so what I've done now is I've filled the lungs up with this 300 extra milliliters, okay, when they were bigger. But now I've made the size of the lungs smaller, but I put extra air in. What's going to happen to the pressure? It's going to go up. So because we put this extra 300 milliliters of air into the lungs, made the size of the lungs, the volume of the lungs smaller, pressure goes up. And we started at a pressure of 760, and the pressure has just gone up about 4 millimeters of mercury, so now we're at 764 inside the lungs. So, the pressure in the lungs is now higher than the pressure in the atmosphere, and air will push out until we reach equilibrium between the two containers. Any questions? All right, so let's see if you get this, if you grasp what's going on. All right, so I'm going to make a specialized room, okay? It's my own magic room, so I can do whatever I want in this room. So I'm going to make this real special room. And we're going to put a two-way mirror in this room so we can all watch what's going on inside the room. And the one thing about this room is I can press a button and change the pressure in the atmosphere instantaneously, okay? So we'll just like take an anatomy student because we don't care about them. We'll put them in our little room, okay? And we're going to make the pressure in our room 760 millimeters of mercury, like it's at sea level atmospheric pressure, okay? And we're going to watch this student in the room. We're going to watch him inhale and exhale, and inhale and exhale. And right before they inhale, I'm going to change the pressure in the atmosphere from 760 to 764. What will happen? Think about it. Right before they inhale, I'm going to change the pressure from 760 to 764. Okay, now here's the trick. This is all you got to remember about which way air goes. It's always going to go from high pressure to low pressure. So what's my pressure going to be right before I inhale? Right as I'm lifting my chest and I'm just starting to inhale, what's the pressure in my lungs? Look at your notes. You wrote it down. What's the pressure in my lungs as I'm lifting my chest? 756. And what did I do to the pressure in the atmosphere? I made it higher. I made it 764. So now the pressure in the atmosphere is much higher than normal, and the pressure in my lungs is only 756. Which way will air move? In. That person will take in a deeper breath than they thought they would. Like, when they just thought that they were just going to breathe normal. So after you're done laughing, we'll do this again. Just joking. You'd be laughing at them if you got to see it, because it's funny. I've seen it happen to people. It's really funny. Okay, so now we're going to, get them back to normal, and we'll do 760 in the chamber, and they're inhaling and they're exhaling, and they're inhaling and exhaling, and right before they inhale, I'm going to change the pressure in the atmosphere from 760 to 756. What will happen? Think about it. Instead of being 760, it's now 756. What is the pressure in this person's lungs as they start to inhale? 756. And what is the pressure in the atmosphere? 756. What will happen? Nothing. They're going to try to inhale and nothing will move. They won't get any oxygen in. They won't get any air in because there has to be a pressure gradient. It has to move from high pressure to low pressure. If the pressure in the atmosphere equals the pressure in your lungs, no air will move. How cool is that?
So what does it look like when you're doing that?
It's like a little fish out of water. Nothing goes in. That's pretty bad. Okay, let's try it again. All right, so see, I told you it's funny. Told you. Okay, so it's my demonstrations, yes, but that's what they would look like too. Okay, so we're going to inhale and we're going to watch them exhale, and they're going to inhale. Now, they're going to exhale this time. So just as they begin the exhale, I'm going to change the pressure in the atmosphere from 760 to 764. So look on your notes. What's the pressure in a person's lungs as they begin to exhale? What's the pressure in their lungs as they begin to exhale? 764. 764 as they begin to exhale. And what did I just put the pressure in the atmosphere as? 764. Will they exhale? Nope. Nothing will happen. It's that fish thing again. Okay? All right? All right, so let's try it again. So they're inhaling and inhaling, and they're just starting to exhale. And right before they exhale, I'm going to change the pressure in the atmosphere to 750. What will happen? Huge exhale. Okay? Because what's the pressure in their lungs? 764. Pressure in the atmosphere was 760, so you'd get a little exhale. But if you make the pressure difference really big, like 756 or 750, you'll get this huge exhale.
Question. How does yawning work?
Nobody has a clue. Nobody knows why we yawn, how we yawn. The fact that we talk about the word yawn makes us yawn. I'm sitting here going, don't yawn, okay? Just as I'm saying the word. Nobody knows. And you know what's really weird? Every animal yawns, even insects. Fish yawn, ants yawn, everything. Every animal yawns. We don't know what it's for. People used to think that yawning was due to a buildup of CO2 in your system and then you had to push it out. That's not true. You don't have any excess CO2 when you exhale. Some people have said that yawning stretches the muscles in the face, which activates an area of the brain called the reticular activating center. This is the center that makes us more awake. See, you're doing it. More awake or more asleep. And you know, if you're like driving and you're really tired and you know, try to stretch your face and you hit your face, that kind of thing, it does help a little bit to somewhat. So maybe, but nobody has a clue why it happens, why it's so contagious. Nobody knows.
Yeah.
Don't know.
I read that you yawn because your brain needs to cool down. I don't know.
I have never heard that one before. But I don't know what yawning would do for you, because that's coming from your stomach, from your lungs. By the way, here's something that sounds even more stupid, but this is actually true, and I've never heard that, so I can't comment one way or the other. But you know when you get a brain freeze because you're eating ice cream or drinking something too fast? It's actually referred pain. Your brain doesn't hurt. It just thinks it does. What really hurts is your stomach. So if you can warm your stomach up really fast, the brain freeze will go right away. So one thing you can do is like blow into your hand, which pushes some hot air back into your stomach, and that'll make it go away faster. Or if you drink something a little bit warm, it'll go away right away. It's referred pain.
God, it is crazy.
Like a trigeminal headache.
Yeah. Mm-hmm.
Well, what about when you have the hiccups?
Okay, if you have the hiccups are a spasm of the phrenic nerve. And the phrenic nerve is making your muscles jump, okay? I can tell you the absolute 100% for sure will always cure your hiccups, but it's a little gross. Part of your phrenic nerve travels through the roof of your mouth. And you have to have somebody else do this for you. You absolutely you can't do it yourself. It doesn't work for whatever reason if you do this yourself. So whoever's going to do this, make them wash their hands first. And what they have to do is you have to sit there as relaxed as you can with your eyes closed. And they have to put their finger in your mouth and tickle the roof of your mouth till you just can't stand it. And I'm telling you, if you get bad hiccups, I promise they will go away every single time.
Why can't you do it?
Because I don't know. I'm not even going to guess. I don't know why you can't do it, but you can't do it yourself. Probably because you wouldn't do it until you can't stand it.
So why do little kids have hiccups more than adults?
They don't. Lots of adults have hiccups. And one of the theories of hiccups is that it's from an allergy.
Yeah, maybe.
Well, because they say that, like, when I was pregnant, my son had hiccups all the time. Like,
Isn't
didn't
it
matter
annoying?
What I ate, what I didn't eat, what I was doing.
It's so
like, he would
annoying.
just have the hiccups all the time.
But adults can have hiccups too. Some people have
I
hiccups for
have it
years.
all the time.
Yeah.
Well,
Years.
I have it like at least.
They haven't tried the Dr. Harvey cure for hiccups, though, I'm sure,
Yeah,
because they would go away. Question?
So then what's the difference between when someone has to, like when they take in a deeper exhale because of difference in pressure, and then when you were talking about like a few weeks ago when you see people who will like randomly like breathe in really deep?
Okay. That random breathe in really deep is usually due to stress. And the stress hormones can affect the medulla to force you to go, because usually when a person is stressed, they forget to breathe. And you'll sit there for a long time not breathing. And then you have to breathe.